I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about a controversial topic, and that is embryo banking. I will say, I help to moderate a Facebook group for female physicians with infertility, and one of the number one topics that comes up in that group is, when do I start transferring my embryos, and how many embryos do I need to ensure that I can have one child, two children, three children, whatever the number is. I will say that it's a balance, because I think that in coaching school, I was always taught that we need to have an abundance mindset, not a scarcity mindset. And that's how we manifest good things in the universe. Hey, I know that sounds super woo, but I really think there's something to that. I really do believe that we need to believe in possibility. We need to believe in abundance. I also think that at the same time, we need to be practical in terms of taking practical steps forward to encourage that abundance will come to fruition, right? So it's sort of, how do we get out of the scarcity mindset? How do we get out of the super type A controlling, fearful state and come to a more sort of peaceful, hopeful, and also at the same time very practical and ambitious mindset in terms of doing all the things to maximize the chances that our ideal family size will come to be. So this is a very controversial topic. It's very hotly debated. You can get probably 5 REIs in a room and everybody might have a different perspective on it. So again, this is my perspective, not medical advice. I've been doing this over a decade, and I've also, been able to see the rise, and I will even say maybe start to fall of PGT technology. Like, I think that everything in medicine at some point gets, very hot, and then people start to see the limitations and it falls into favor. So I'm old enough and seasoned enough that I've seen some of those cycles already. And so what I'm going to give you is my best scientific perspective, my perspective based on experience. And of course, with all things, my perspective that with anything medical, it requires a tailored approach. It is not a one size fits all. The same, sort of clinical situation will not look the same in two different people who have different values and different goals and different, maybe cultural values, like all those different things. And so this is not an algorithm. This is to say, like, these are the things to consider to help you make your best empowered choices as it pertains to, like, how long do I stay on this sort of train track of embryo banking? And when do I start the transition to actually transferring these embryos in a way that I'm not panicking, because I trust that there's enough there that I will be able to have my desired family. Okay. So let's go back to the basics in terms of like a euploid embryo. What is that? Now, I do have a full episode on this on PGT technology, so please do listen to that episode as well if you want more background information. But a euploid embryo, and I say I'm starting here because I think when we talk about embryo banking, a lot of times we're talking about really banking euploid embryos. So a euploid embryo is an embryo that has an egg that's been fertilized in the lab. It's grown to day 5, day 6, and maybe even day 7, and a small sample, so like maybe 3 to 5 cells or so from the trophectoderm layer, which is the part that becomes the placenta. Those cells are sent off for genetic analysis alongside, while the embryo itself is frozen and safe in the freezer, such that, say somebody makes like 4 or 5 embryos in an IVF cycle, you get a report that says, okay, embryo number 1, aneuploid for this reason. Embryo number 2, euploid 46XY. Embryo number 3, aneuploid for this other reason, or maybe a complex aneuploidy. Embryo number 4, 46XX, euploid. So I think that we get the report and it says kind of what the data are, But the thought is that if something is aneuploid, it's probably not going to make a viable pregnancy. And so we focus our attention on the embryos that actually have, a set of chromosomes we expect to be viable, such as 46XX or 46XY, and then we go from there. Now this, as I talk about in the other episode, this gets even more complicated because there's all sort of mosaicism that we can talk about. So maybe, some of the cells express certain chromosomal patterns and others express different patterns. And so the question is, like, with those sort of mosaic embryos, are they viable? Are they not? I think the bottom line would be that some are viable, some are not. There's a little more efficiency in an embryo that's called fully euploid compared to mosaic, but, sometimes mosaic embryos are transferred and do result in live births. And I'm of the mindset we don't want to throw away any embryos that could potentially make babies, right? That's sort of where I come from. So again, with the patient's ideas in mind, client's ideas in mind, but like, I think we want to err towards not throwing away good embryos if we can avoid it. So when we talk about embryo banking, it's sort of this notion that, the first euploid transfer has about a 65% chance of success. The second euploid transfer, if that doesn't work, has about an 80% chance of success. And the third euploid transfer, for those people who are lucky enough to make 3 euploid embryos, the third euploid embryo transfer has about a 95% chance of success. So that means that for people who have had 3 euploid transfers, 95%, and by success, I mean like live birth, 95% of those people will walk away with a live birth. Now, so when you're thinking about it, say you're 38 years old and you have PCOS and you want 2 children, how many embryos do you decide to bank before you start transferring? So say, for instance, you're 38, you have an embryo transfer, it works. You end up being pregnant for 10 months, you deliver, you breastfeed for a year, and then you wake up and you're 40 and you're like, oh my goodness, it's so much harder to make embryos at 40 than it was at 38. Maybe I should have banked more embryos. Like, that is the situation that everybody is afraid of, like wanting more children, being older, and having regret about not freezing more embryos on the sooner side. Now, the problem is nobody has a crystal ball and can say, well, for you in particular, this is how many embryos you need to generate to get to your ideal family size. And once a person's pregnant, I mean, that's a kind of a big commitment. We're not supposed to even do IVF when breastfeeding. I know it's controversial, but still, like, it's kind of like you lose a couple years at a time. So there is this notion out there that you need 2 to 3 euploid embryos per live birth that you desire. Like, somehow that got into the literature. And I think, or that not even literature, like the sort of social constructs. I think it comes from the literature that I just cited that, like, after 3 euploid embryos, there's a 95% chance of a live birth. And so if you think about it, you're like, okay, well, if I have 3, that's a 95% chance. And then if I have another 3, that's another 95% chance. And so people kind of get sort of sucked into this scarcity. Like, I only have 2 euploid embryos. That doesn't even equal 1 live birth. And that is just not true. Like, it's how our brains work. Like, is that we sort of think, okay, well, I have to have 3 and I don't, so it's not going to work. But 2 euploid embryos could actually be 2 live births too. I've seen that time and time again. I mean, this is the thing, is like, how do we proceed in a practical way while at the same time not being cavalier and saying, like, well, obviously it's going to work for me, so I'm going to just like move forward and hope for the best, right? So there's like this line that we walk. So here are the things that I think about to help each individual person. Again, I want to chuck that 2 to 3 embryos per live birth out the window. It's like nails on a chalkboard when I hear it, because it's like people are not thinking. It's like think. Like, this is not like just blanket one size fits all medicine. We have to look at each person in front of us and make the best decisions for those people, right? Like help them make those decisions, but it is not as simple as just 2 to 3 embryos per live birth. Okay, so the first question I start out with is, like, what is your ideal family size, right? I think about this much differently if somebody tells me 1 child versus if they tell me 3 to 4 children. Those are very, very different goals. And especially when pregnancy is as long as it is, and maybe people decide to breastfeed, like, we have to think very proactively if somebody wants a larger family. But I think if somebody wants 1 to 2 children, it's sort of simpler in terms of thinking about what the targets are. Understanding that time is a continuous variable and time continues on. So desired family size is like a really, really important question. And I think it's also helpful to think about, okay, well, our initial vision was 4 children, but now, I mean, after all this, I think we'd probably be happy with 1, maybe 2. I'm not saying we give up on the vision, because I think it's really important that if 4 children is really important to us, that we keep that, top of mind. I also think that sort of understanding if there's any flexibility with the original goal, that can also be really helpful, because then it just gives a little bit more breathing room, a little bit less pressure in the situation, and it just can be helpful for thinking outside the box about things. Okay, so desired family size, super important. Age and diagnosis, also very important. So I think about somebody very differently if they're like 30 or 32 than I do if they're like 39, 40, 41. Like if you're 41 and you want 2 kids, like I want you to bank the crap out of those embryos as long as the cycles are going well, because we can't get back that time. And even 41 and 43 are very different numbers. But if somebody is 30 with decent egg reserve, then, sort of we have more time, we have more ability to maybe do another cycle in the future. And so, all those things come to mind. I think about the diagnosis as well. I mean, diminished ovarian reserve is very different than polycystic ovarian syndrome. So if somebody really does have diminished ovarian reserve, and I'm worried that that's going to get worse with time, I think about them with a little bit more urgency than I do somebody with PCOS who makes lots of blastocysts, who is expected to have, good euploid. I also think about endometriosis. And so like endometriosis is one of those things that can be progressive. It can make fertility less efficient. There's some data that embryo transfers for somebody with endometriosis are about 10% less than people without endometriosis in different diagnoses like PCOS and male factor and such. And so if somebody has endometriosis and maybe they have pain, maybe they have more surgery coming down the pike, those are people that I sort of think about more critically in terms of like, okay, like what are the goals? How many embryos do we have? Like, embryo and endometriosis tends to get worse over time, especially if it's been recently treated. Do we just like get as many as we can and then suppress the heck out of that person and then do the transfers? So that's another situation I think is really important to think about. So that's the second question. What's the age and diagnosis? The third question is, what did it take to get to those embryos in the first place, right? So say somebody does like, a cycle of IVF, but they are sick as a dog. They got terrible ovarian hyperstimulation syndrome. They had to miss 2 weeks of work. They had to get tapped, had to get anticoagulated, like all those things. Like every single IVF cycle is not the same. Every single person has a different threshold of how they tolerate it. In my experience, people with more vigorous stimulations, tend to have worse times of it. And I also think that like, were there any complications? Say somebody had a complication from IVF, like that person's probably going to be a lot less likely to move forward with another IVF cycle gingerly, right? Like say somebody had a blood clot, say somebody had, a bleeding event. I mean, I know those things are pretty rare, but if that happened to you, I mean, I would be a little more gun shy about signing myself up for another IVF cycle right away. So in that situation, I'd say, okay, well, what do we have at the present time? And how does that align or not align with the goals? Say somebody got 8 untested embryos from an IVF cycle where they got really bad OHSS, they might say, you know what are your goals? Like, let's proceed on. But if somebody maybe got no embryos from that cycle, and they really want to have a family, I might say, okay, well, what could we change moving forward to make the cycle go better the next time and be more tolerable? So that question of like, what did it take to get to those embryos? I think in terms of efficiency, I mean, some people will tell me, yeah, I have 3 euploid embryos, but it took me 12 IVF cycles to get there. That's where I might say, okay, like, let's talk about that, because at what point does the process of IVF seem to be counterproductive? Like, I've also had people tell me in my coaching hat, like, it's a lot easier to do IVF cycles and just show up and get the blood work, get the ultrasounds, than deal with the potential of it not working, i.e. doing an actual cycle. So I think sometimes we stay stuck in like embryo banking mode because it feels safer, when in reality, it's like, okay, the efficiency is not very high. We're lucky to have these embryos that we do. So maybe it might make sense at this point to like, obviously do as much proactively as possible, but really start to think about transferring, especially when the body is telling us that, more IVF may not be fruitful. What else? Finances. I mean, some people have, insurance coverage, and they are still able to get more treatment cycles covered. And that's sort of one consideration. Other people, maybe they had insurance coverage and now they're out of pocket and they have some reserve, but not indefinite reserve financially. And then other people have been paying out of pocket the entire time. And at some point, it's like, okay, what other financial goals do we have? And how much are we really willing to sink into this process? Now, I'm of the belief that like a child, if that is your deepest desire, it does not matter how much, we spend, because that is just the most beautiful blessing at the end of the day. I wish that we had more universal coverage, of course, but like, I think that, if your goal is to be a parent and you're hoping for one child, I do think that like financially, it's like, okay, let's do everything we can to make this a possibility, even if it's a loan or like any of like, I understand like we don't want to live with regret. We want to do as much as we can. And usually the finances are not the issue, but at some point it's like, again, looking at that sort of ratio of like, how many cycles have we done? How efficient have they been? How likely am I to get another good embryo if we do another cycle? And what other financial priorities do we have? Especially, I've seen people sitting on like 5-6 euploid embryos in the freezer being like, oh my gosh, I think we have to do more. I think at that point, it starts to become like that scarcity mindset where it's like, are more embryos going to be beneficial? Are they not? Like, what happens if you reach your family building goals and you still have 4 euploid embryos left? Some people have serious moral and ethical, opinions about that. Other people don't. But like, hey, I'm here to meet people where they are. And if that is a concern that having excess embryos actually might create a different sort of a problem, then we want to talk about that ahead of time, because embryo banking just indefinitely is not always the right solution. So I think, that sort of third question of what did it take to get to the embryos, cycle tolerance, complications, efficiency, finances, those things are really important to think about. Okay. Fourth question is, what is the clinical history? Like, has somebody been pregnant before with maybe a live birth and now they have a new partner and they're trying again? Has somebody been pregnant before but has never had a live birth? Maybe they've had 4 or 5 miscarriages, and so that's something to consider. Has somebody had a prior transfer before? If somebody comes to my office and they have recurrent implantation failure, they've had 5 embryo transfers and a mix of biochemical pregnancies and non-pregnancy cycles, I'm going to think about them very differently than I do somebody who is like a G2, P2 in their, maybe it's been a few years, but they have a new partner and they want another child, right? Those are very different uterine environments, very different situations. So the clinical history really does matter. And then, my next question is, can anything be optimized prior to the transfer? So some people are as optimized as they can be. Like, they've had all the testing and, everything else, and they're like ready to go. So what does that look like for me? That looks like, a uterine cavity test that's up to date, either a sonohystogram or an office hysteroscopy or an OR hysteroscopy, some sort of a recent cavity evaluation. I like them within 6 months. I know some clinics say 12 to 24 months, but just really recent, a look to say the uterine cavity cannot be optimized anymore. There's no polyps, there's no fibroids, there's no retained tissue from any other losses, there's no scar tissue, like all those things are set. At the same time, I also like a endometrial sampling if possible, right? Especially if you're like, hey, I want to make the best use of these embryos as possible. It's not comfortable. It's an endometrial biopsy. It takes about 5 to 10 seconds to get that tissue, to send it off to pathology to look and see if there's any plasma cells, also known as CD138 cells, because we know that 8% of women walk around with chronic endometritis, and in patients who are infertile or have recurrent pregnancy loss, if you treat the endometritis, then the clinical outcomes are better. People get pregnant better, more efficiently, they stay pregnant more efficiently, and they have higher live birth rates. One weekend I pulled up and read like every single paper I could on chronic endometritis. So I feel pretty up to date. I've even recently had a conversation with a GYN pathologist about it. So I think thankfully we as a field are coming around that this really does matter. But there was my Michigan accent coming out. Listen to that. But I think that uterine health is really, really important. And if you've taken the time and the energy and the expense to go through these cycles to generate these embryos, you really want to make sure the environment is as optimal as possible. Now, I will also say that there are people who do worry about what's called silent endometriosis, and I have a whole other podcast episode about that, so please do listen to that. If there's any suspicion of endometriosis, I think it is useful to, do either some testing ahead of time for endometriosis, or even empiric treatment, spending 2 to 3 months on Lupron suppression, plus minus some other adjuncts like letrozole, Agestin, and really kind of calm the inflammation down so that the environment is as optimal as possible. It is very controversial, but I think that like I see people blow through like 2, 3, 4 euploid embryos. They're not pregnant. I see in my coaching practice the 5%. Like most of my clients have already had at least a couple euploid embryo transfers and they're still not pregnant. So again, not everybody, but still. So I'm used to thinking about the 5% of people who are not in that live birth category yet. So, but I do think that an endometrial biopsy is a simple enough thing to do that I do think that even before a first transfer sometimes, I mean, I know that's controversial because there is some harm there. It's painful, but I think that making sure that there's no inflammation present before a transfer, it's a pretty low hanging fruit. And I think that treating endometritis if present has been shown to improve outcomes. Now, the ERA test, I get a lot of questions about that. The ERA test, endometrial receptivity array, is a test looking at like doing a practice embryo transfer cycle, and everything is the exact same as it would be compared to a normal embryo transfer cycle, except on the day of the quote unquote transfer, the embryo is not thawed, an endometrial biopsy is done, and then that tissue is actually sent off to a special company. There's actually now a couple companies that are doing this to see if that endometrium is receptive, like at that time in terms of progesterone that we would expect the embryo to stick. Now, I do believe that the uterus, like the uterine lining, the endometrium, and the embryo should be like Velcro. They should sort of be able to stick together. There are some situations in which the sort of Velcro is a mismatch. It's a timing mismatch, and the age of the embryo and the age of the endometrium, even if they line up on paper, don't line up molecularly, that can happen. I think that is the sort of very small subset of patients. In my whole career, I can only think of a handful of patients who have really needed ERA, in my opinion. I know it's controversial, to have their children. And I think that there can be some harm too. Like, what if we say that somebody's window of implantation is like different based on the testing and it's not an accurate test, and then we make them take less or more duration of progesterone, and then that's not actually going to help, it's going to hurt. So, unfortunately, the initial data that was very pro ERA was proprietary. And so the company that sold the ERA was the ones doing the research. Again, it's so hard. Gosh, again, on the day of this recording, there's all sorts of things going on with funding and research and how we get our scientific answers. And so I do understand that industry does play a role. I also think that, some of the data that have come out sort of after that have not been as biased connected to the source of the sort of the outcome in terms of that conflict of interest. I think that data has not shown in population levels to improve outcomes. And so again, I think in general, I don't recommend ERA testing. I think in somebody who's had, say, a couple of euploid transfers and things haven't taken, it could be explored. But I also think the window of implantation is a lot more sort of wide and complex than we understand. And so I'm not as much of a believer in the ERA as I used to. I think that if there's sort of clearly not treatment success happening, it is something that can be undertaken to try to get some answers and try and maybe optimize the next cycle. Similarly, with adenomyosis, I'm about to give a talk at my university about adenomyosis and fertility outcomes. I think that that's something where sometimes on ultrasound, we can have a suspicion that it's present, on MRI as well, looking at the junctional zone. Most of us in our 40s are going to have some adenomyosis, and previously it was thought to be a disease of like fertile women. And so unless it's really bad or severe, I usually don't recommend sort of intervening. Adenomyosis and endometriosis can go sort of be comorbid. And so it is something to think about if there's adenomyosis on imaging, like if there's also endometriosis present as well. But I tend not to get too worked up about adenomyosis, even though I know it is part of uterine health, unless it looks really severe on imaging or somebody has had unsuccessful transfers and nothing else has really come up in the evaluation. So uterine health is definitely something to think about. Can it be optimized prior to a transfer? I also look at lifestyle stuff. I mean, the vast majority of my patients and clients are already doing everything that they quote unquote should be. I think looking at weight is a controversial topic as well, but like if somebody really has, sort of a high BMI and it's thought that could be optimized, we do know that adiposity is a pro-inflammatory state. I spent my whole fellowship trying to understand these things. We just had a lecture recently on BMI and outcomes. And I mean, some studies show 10 to 15% decrease in pregnancy rates for women with high BMI. And so it's like, okay, if you work so hard to make those embryos, like let's really put them in a optimal state, whether that's initiating a GLP-1 for a few months before doing a transfer, or impaired glucose tolerance is another one of my favorite things. Like it's like an A1C of 5.9 is not ideal. Like embryos don't like the sugary environment. So, and that's something that really can be reversed. And so really just spending 2-3 months even optimizing that environment, I think can make a big difference for people's outcomes. And the whole point is to understanding the efficiency is not 100% to try to be as efficient as possible. Stress reduction too. I get a lot of questions about stress reduction. It's so interesting to think about why women physicians have such high rates of infertility. And I really do think that part of it is because of deferred childbearing. I mean, that's undeniable in terms of medical school and residency and fellowships and all those things. But it doesn't explain everything. I mean, even age-matched controls, women physicians and women surgeons, actually especially, have worse outcomes compared to non-physicians with the same age and diagnosis. So there's something else that's going on that's beyond deferred childbearing that is playing a role. And I mean, I think part of it is probably the stressful nature of the job and all the night shifts and all the long surgical days, and that very stressful environment gets the adrenals going, gets the cortisol levels going. And so, yes, our jobs are very stressful. How do you control for that? I think, that's a whole other conversation in terms of like maybe stepping back a little bit professionally while this process is ongoing, or maybe talking with your chief about reducing night shifts if you're, say, an ER doctor or surgeon or an OBGYN or somebody else who sees a lot of nights. That is a whole other conversation. But I think there's also a lot that can be done in terms of mindfulness and looking at negative thought patterns and shame and self-judgment. We female physicians and women professionals, I know engineers, I have an engineer sister and an attorney sister. I always think about them and their people too. I think about how hard we are on ourselves and how our inner critic is so turned up, right? Like we are just like blaming ourselves all the time, not good enough, like not, smart enough, not, fertile enough, like whatever it is that sort of we crack the whip on ourselves so much, too much, in my opinion. And so it's really turning that inner critic into an inner coach. That's one of my favorite things to help people with. So that internal environment is not as much one of stress, but one of self-compassion, truly. Again, sounds very woo, but I promise you it works. You kind of have to try it to believe it. But that's one thing I help people with all the time, is to turn down the dial on the stress. And I think, if there is something excessively stressful in your life, if there's I don't know, like a lawsuit or a sick family member or an impending move or something, like I think about these like very stressful situations, like maybe take a break from the process for a few months and then re-engage once you know that you're not dealing with like 5 million stressful things at once. So that's my thought about stress reduction. So, in summary, we talked about a lot of things today. We talked about, basically the big topic being embryo banking and when to know when to start transferring the embryos. And what I really wanted to do is debunk the myth that like every single person on this planet needs 3 euploid embryos per desired child, because that's just not the case. Like, that's just not the case. It depends on a lot of various factors. It depends on age, depends on prior history, depends on, what it took to get to those embryos, and what can be optimized prior to a transfer. So, I think about this, like, say you have 4 euploid embryos in the freezer and you really want 2 children, and you're like, I don't have 6 euploid embryos. My doctor said I needed 6 euploid embryos before I started transferring. I might take the approach like, hey, you have 4 euploid embryos. So many people kill to have 4 euploid embryos. Like, that's amazing. So why don't you do the first transfer after we make sure that every single thing is optimized that we can, and see if it takes. If it takes, guess what? You go on, you have your live birth, you have 3 euploid embryos in the freezer for your desired second child. Done. Case closed, right? But if the first transfer doesn't work, and then you're like, okay, well, thinking about maybe doing a second transfer, maybe that's a situation where you decide to do another embryo banking cycle, or maybe you decide to do the second transfer and then say, well, if that doesn't work, then I'm going to, sort of go do another banking cycle too. So I think there's all sorts of different sort of approaches, but I really wanted to say that in somebody who has good uterine health, especially in somebody who's had a pregnancy before, I even have clients who get like one euploid embryo and they only want one more child. And they're like, you know what? Like, I'm going to transfer it. I don't want excess embryos. Like, and if it doesn't work, I'm going to go right into another cycle. I understand people can have miscarriages and their pregnancies can, prolong and everything, but I really think we have to think outside the box about this. I mean, we do that in every other aspect of medicine, like personalized care, cardiology, depression, all these other aspects, GI, like all these other places where we are understanding that each person's an individual. We really need that same tailored approach in fertility medicine. I think we have to look at the whole picture and what somebody's goals are, what their personal situation is, what can be optimized, what can't be optimized. My people know I'm obsessed with the serenity prayer. What can we control? What can't we control? And then make the best decisions. So please, if you walk away with only just one thing, it's that, that sort of maxim 2 to 3 euploid embryos per desired child, that is overly simplistic. And you really need somebody who can help to look at you and look at your situation, look at your goals, and help you create that abundant mindset and also be abundantly practical at the same time to really help you achieve your dream family and your dream goals. So with that, I love you. And if you have questions, send me a DM. I'd love to help you in particular sort your situation. More science episodes to come. Bye. Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.